Good day, everyone. My name is Onowori Victor. I am a neurology applicant, and I will be doing the Cheng Ching Comprehensive Review in Clinical Neurology. We've done questions 1 to 25, and right now we are going to do 26 to 28. So let's get started. We have question 26. A 29-year-old woman with a history of hypertension presents with complaint of right eye pain on eye movement, impaired and blurry vision, and the feeling that some colors do not look right. Now, on swinging light test, when light is shown to our left eye, both pupils constrict normally, which is a good response. Then, when light is quickly moved to the right eye, both pupils dilate slightly. Now, that is not supposed to happen. And the amount of constriction is much less as compared to when the light was shown to the left eye. So, something is definitely ongoing in the right eye. Now, our visual acuity is impaired in the right eye and red color perception. Which of the following is the most likely cause of this patient's finding? So, this is looking like a clinical case of someone who has optic neuritis. And why would she have optic neuritis? One, look at the age. She's 29 years of age. Optic neuritis can affect women in their 20s and their 30s. And two, she's a female. The disease has a predilection for females. Three, there is something we call a relative afferent pupillary light defect, which we're going to talk about shortly. And she also has um, a defect in her red color perception, also known as red color saturation, which we're also going to talk about. These are classical features. This question is actually screaming optic neuritis ongoing in her right eye. So let's see what the options are. The first is bilateral optic nerve disease. So we've already established that left eye is fine. So it's not bilateral. B, severe bilateral, so nothing bilateral. B is out. C is left lateral geniculate body lesion. D is right lateral geniculate body lesion. And E is right optic nerve disease. So, like I said, this question is screaming optic neuritis. So I will go for options E. So let us quickly talk about this. Like we said, the finding is called an RAPD, a relative afferent pupillary defect, also known as the Marcus Gunn pupil, and it is commonly caused by a lesion anywhere from the optic nerve to the optic chiasm. Now, in normal eyes, the reaction of the pupils to both eyes are actually linked. In other words, if you shine bright light on one eye, it leads to equal constriction of both pupils. And when the light source is taken, both pupils will actually dilate equally. Yeah, and we call this the consensual light reflex. Now, there's something we call a swinging eye test that can be used to detect relative afferent pupillary defects. And basically, you try to find out the difference between both eyes and how they respond to light that is shown in each eye individually. Now, so how is this done? Basically, you shine light in the first eye and you let that light stay for 3 seconds. And the normal response, the pupils that you are shining the light on reacts briskly and constricts fully to the light. And if you check the other eye will also constrict in the same degree to light. And that's called the consensual reflex. Now, you quickly move that light to the other eye for 3 seconds and you have to observe the changes to the pupil. Now, that pupil that you are shining light on, the question is, does it remain the same? Does it constrict further or does it dilate? Now, if there is no RAPD, both pupils should actually constrict to the light that is shown on the opposite light as well. Now, when you have a patient who has RAPD and you shine light on the affected eye, what happens is that both eye will actually constrict, but that constriction will not be as much as if you shine it on a good eye. So you have a diminished constriction. Now, this is explained by the fact that there is actually a defect in the afferent pathway in the affected eye. Now, when you now put light in the normal eye, you will now see that both pupils will actually constrict much more than when you put the light in the affected eye. And when you shine the light back into the affected eye, you will then see that the pupil will dilate rather than constrict. Generally, retrochiasmal lesions do not cause a pure RAPD. Retinal lesions, refractory errors, and myopia, disease of the lens, all will not cause RAPD. Now, it's important to note that if you have a lesion in the lateral geniculate body, that will affect vision, but that will not cause any form of pupillary issues with pupillary response. So back to our question, we've already established that our answer is um, right optic nerve disease. Okay, so for question 27, we have a fundoscopic examination of the right eye shown in figure 1.3. What diagnosis do you suspect? So let's look at this fundoscopic examination. We can see the optic disc is actually is looking enlarged. There is blurring of the margins of the optic disc, and that is actually a classical sign of optic neuritis. But we've already established from the clinical presentation and symptoms. So yeah, basically optic neuritis. Also, our pick option is D. So question 28, a brain MRI with contrast confirms your suspicion. Which of the following will be the most appropriate next course of treatment? So options A, oral prednisolone taper. Options D, IV methylprednisolone followed by oral prednisolone taper. C, observe, initiate treatment at the next episode. D, begin interferon therapy. And E, begin plasma exchange therapy. So for this particular question, before we actually jump into the answer, there is something I need us to quickly review. Now, there is something we call the ONTT, the Optic Neuritis Treatment Trial. And basically, what they did was to randomize patients into one of three groups. The first group actually had oral prednisolone for 14 days and a 4-day with a 4-day taper. The second had IV prednisolone, followed by an 11 days of prednisolone with 4 days taper. And the last actually had placebo for 14 days. Now, those who had the IV methylprednisolone group actually showed fast recovery rates, so they recovered faster. But after about 1 year, the outcome of their vision was similar to those who were placed on just oral um, prednisolone and even oral placebo. Now, the IV methylprednisolone group also had a reduced risk of conversion to multiple sclerosis within the first 2 years with other groups, but at 5 years, there were no difference in the rate of multiple sclerosis between the treatment groups. Now, interestingly, only those with the oral prednisolone group had a 2 times increased risk of recurrent optic neuritis compared to both the IV methylprednisolone and placebo group. And at 10 years, the risk of recurrent optic neuritis was still higher in oral prednisolone group when compared with the IV methylprednisolone group, but not in the um, placebo group. So, so our answer will be options B, the IV methylprednisolone followed by the oral prednisolone taper, because that actually has a much more superior, or a much more better visual outcome and a lesser risk of recurrent optic neuritis after 2 years. So that's basically it for now. See you in the next episode.